Main challenges in treating older, unfit patients or high-risk patients with acute myeloid leukemia is that they're often resistant to standard chemotherapy. So the standard therapies that we've used for AML are usually cytarabine-based treatments like 3+7 or FLAG-IDA or CLIA. And we see that in patients who have the adverse cytogenetics or adverse molecular features like TP53, the response rates to these therapies are much lower in about 40 to 50% CR/CRI range compared to about 80% in patients who don't carry these adverse cytogenetics or molecular features. Also, in older patient populations, regardless of the molecular or cytogenetic features that they have, we do see that these patients are more high risk for having toxicities and early mortality from these high intensity chemotherapies, with early mortality ranges being reported anywhere between 8 and 25%, especially in patients who are above 70 years of age. And so I think these are the main challenges in trying to use the traditional intensive chemotherapy in either the older unfit population or in patients with high risk adverse cytogenetic molecular features. For older AML patients, there has been progress in the last 5 to 6 years. And the first step was actually the emergence of a combination therapy of a drug called azacitidine in combination with venetoclax. So the standard approach in the prior 2 decades for these older unfit patients, where we expected the induction mortality with high dose cytarabine anthracycline therapy to be high, was to use what we call hypomethylating agents. And there were two hypomethylating agents approved and being used across the world in the frontline older unfit AML population. These were azacitidine and decitabine. And as single agents, these gave response rates of about 25 to 30%. A major improvement came with the emergence of a drug called venetoclax, which is a BCL2 inhibitor. And when we added venetoclax to the azacitidine or decitabine backbone, we saw that the CR/CRI rates were more than doubled, going from 25-30% to about 70%. And the median survival was also improved from 8 months to about 15 to 17 months. So this was the first major step in improving outcomes for older, unfit, as well as high risk adverse cytogenetic molecular feature AML. But in spite of that progress, we see that the median survival is still only 15 to 17 months, and the 2 year survival is only about 35-40%. So it's a good first step, but we wanted to improve this further. And so we've been looking for other therapies that could be added to this new azacitidine venetoclax backbone that could be delivered safely without additional myelosuppression and improve response rates and eventually survival. One of those that has emerged as a major contender for such a triple combination is a drug called Magrolimab, which is a CD47 antibody. The way this drug works is very unique. It's a immune therapy, one of the first immunotherapies that is showing good activity in AML, and it works by activating macrophages, which are cells that we have in our own immune system that should attack any foreign bodies. And the Magrolimab removes the brakes, unleashes the macrophages, and then the macrophages are able to attack the acute myeloid leukemia cells, resulting in phagocytosis and removal of those cells from the circulation. I think the next major question here is, of course, going to be that whether this single arm, single institution, MD Anderson study showing very encouraging true CR rates, both in TP53 mutated and TP53 wild type older patients, can be translated to a benefit in a randomized phase 3 registration study that will be open in greater than 100 centers. And I think that's what is going to be looked at in the ongoing Enhanced 3 study. The key endpoints for that study are going to be overall survival. So azacitidine venetoclax, it's well established from the previous phase 3 study, gives us a median overall survival of 15 to 17 months. So I think for a therapy to show clear clinical and statistical benefit, we're looking at greater than 21-month median survival, which would probably translate into a 2 year survival of greater than 50%, which would be very encouraging in older unfit AML patients. So I think that will be the primary endpoint. In addition, we'll be looking at true CR rates. Those are about 35 to 40% with aza-venetoclax. And the question is, can we improve those to greater than 60% with this triple therapy? And that has a major impact on quality of life, because once patients achieve true CR, they require less transfusion, less visits to the hospital, less admissions with neutropenic fever. And so it has a logistical, social, economic benefit. And so I think these are the two things that will be evaluated. It's probably going to take about 2 years for the enhanced three large phase three study to enroll and get the data. But of course, if it's positive, could really improve our frontline therapy for older AML, which would be fantastic.